Welcome. I'm Elazar Edelman, and with SCAI, we're delighted to have this panel discussion today accompanying the special issue of AI in medicine and in interventional cardiology. I'm joined today by three auspicious and expert members of our field to discuss AI in innovation and governance, the role of AI in cardiovascular medicine and intervention. And I'll introduce them each together. They'll give their presentations. Rohan Khera is a professor of medicine and of biostatistics. He's the clinical director of the Center for Health Informatics and Analytics at Yale, where he also directs the cardiovascular data sciences. Afnan Tariq is an MD and a JD, an assistant professor at the University of California in Irvine. And we're joined as well by Curtis Rooney, who's the Vice President for Government Relations of SCAI. So with that, I'll pass this over to Professor Tariq to begin our presentation, and then we'll move on to Dr. Khera, and then with Mr. Rooney, the discussion for the panel. Thank you.
Thank you again for the opportunity to speak and to add some color to the perspective of government relations and advocacy as it relates for interventional cardiology and AI. This is an important and timely topic, and Dr. Edelman, thank you for having us here. So I've served on the SCAI Advocacy Committee, and one of the important things that's emerging, there's themes around what AI can do, and that's an important question. There's also an important topic here, which is what should AI do in cardiology, and what can we do responsibly? And so SCAI's Advocacy Committee thought this was a very important topic, and we put our minds together without AI to try to add some color on where we can have responsible use and the role of SCAI as a professional society in governing the future of artificial intelligence in interventional cardiology. Now, at the time of publication of this paper, there were about 98 cleared FDA AI ML devices. At the time of publication of this paper, about 4 months later, there were almost 1,000 devices that were approved from the FDA standpoint. So this is clearly an emerging and burgeoning field, and there are key challenges and risks, and this is something that comes up all the time, but there are challenges around data security, the black box, and also just encryption and standards, as well as AI biases and what the regulatory landscape looks like. I know this is something that comes up quite often, but we wanted to approach it from the mindset of what should the professional society lead with, and where should physicians have a leadership role in this field. We highlighted a number of concern areas. There are obviously opportunities, and Dr. Khera's paper goes really well into the opportunities for AI and its role in clinical care. But we wanted to talk more on the governance side of things. And so there are concerns around bias and discrimination, transparency and accountability, safety. And when we thought about these, we thought that there is a clear framework from a society perspective, which is how do you ensure responsible and safe patient access? And how do you enable physician autonomy and the physician role in cardiology? And so that's a lot of what we wanted to approach. And currently AI is starting to touch these areas. And there's a lot of, there are a lot of regulatory bodies that are emerging, and there's no consensus around this. And physicians, there should be physician input that has a strong role in these, and that's one thing that we really want to position forward.
Thank you very much, and maybe this is a perfect segue into Professor Khera's presentation.
Thanks for having me here. I'm glad to talk about the article that, we could contribute to this special issue of JSCAI. Our goal was to provide a comprehensive overview of how the applications of artificial intelligence would potentially change the field of interventional cardiology. We focused on many aspects of this, and this is a broad overview without going too deep in any one of them in detail. We focused on how diseases that matter for the interventional community are diagnosed, how we can assess the outcomes and the trajectory of people, how we can plan procedures before they're done, and how we can guide clinicians to achieve optimal outcomes while delivering these procedures. The key facets that we really emphasize is the fact that many of the structural heart disorders that are an important area that we provide a lot of interventional, I would say, procedural care. Their diagnosis is very limited, and most people do not get diagnosed before the onset of advanced symptoms. And so a big chunk of our work write-up focuses on the idea that we could use simple tools like electrocardiogram, point-of-care cardiac ultrasound to diagnose a range of conditions that merit somewhat structural interventions, including advanced stages of valvular heart disease that is missed during routine clinical care where people don't present with typical symptoms. Similarly, we've found that these tools can be used to prognosticate who has high risk for heart failure and other adverse outcomes, and can actually be used eventually in the future to guide who should receive more urgent care and more advanced care. There is a lot in this space around early diagnosis of even coronary artery disease and advanced structural heart disease that can really change the trajectory of people and their outcome. The second facet that we focus on is procedural related. And again, this is a very highly dynamic field, rapidly evolving, and pre-procedural planning, can go from just knowing the anatomy well to actually now building digital twin simulations of how a procedure would change the gradients and how the valve should be seated and other elements of structural heart disease planning for procedures that can actually be aided by these artificial intelligence tools that can make a virtual replica of how anatomy is there. And finally, there are ongoing guidance systems in the play, which include things that can include ensuring that people can use IVUS and OCT with automated tools, and so we can know exactly if a lesion is obstructive. And similarly in valve as well, knowing when a valve seating and is appropriate, and have intra-procedural TE be automatically guiding how a procedure should approach a certain procedure. So again, I only wanted to provide a brief overview in these comments, but the idea here is that we go from end to end in how interventional care would be different with the advent of many tools in artificial intelligence.
Well, thank you very much. So those are wonderful articles. Indeed, the entire issue is spectacular. With that, I'll turn it over to Curtis and ask you perhaps to lead the discussion of the issue that confronts us all. We're entrusted by patients in their most vulnerable time. They place their faith in us to do the right thing. And now seems to be a pivotal time in both society and in medicine when AI has the possibility of being disruptive. So I guess the question, and I'd love to hear you and Professor Khera and Tariq speak about, is what is the responsibility of us as individuals and SCAI as our constituent advocacy and organizational group to make sure that the best of AI is realized and the nightmares are avoided?
Well, it's a great question, and I really want to thank you for asking it. I also want to thank JSCAI for dedicating space to this issue because it's so important. These two papers are really well positioned. They're kind of the yin and yang of the issue that you're driving at. We talked about in the governance paper about how the fact is that it's the public sector is working on this issue, the private sector is working on this issue, but it's really unbound. And so we wanted to put a stake in the ground as a medical society and answer the question that you ask and make sure the physician's voice is not lost, because this is really just the beginning of the process, I suspect. There are two members of Congress who really deal with this issue, Ted Lieu and Jay Obernolte, not surprisingly from California. And they are trying to do this on a bipartisan basis. But, in our paper, we talk about the fact that the Biden administration put together a pretty fulsome approach and the Trump administration changed it. So we have an opportunity, and I think we should take it.
So I guess with that, to each of you, Professor Tariq and Khera, each of you has your own individual expertise. One of you is a lawyer, the other is a biostatistician, health informatics and analytics. What's the perspective your fields bring on these issues that Mr. Rooney just addressed?
I guess as a reformed lawyer, I'd much rather have AI replace attorneys as a physician than physicians. But I think you highlighted a very critical point, right? We touch patients in their time of most vulnerable and critical need. And patients place an inordinate amount of trust in us as physicians, as very human physicians. Where AI can be a tool to augment that with data, and I'll leave that to Dr. Khera because that's his expertise, where it can be a tool to augment that with data, I think we can utilize it. Where it can augment the human touch and the trust that you feel with your patients, I think there is an important opportunity there. Where it can replace physicians, I think we have to be very careful because that is a concern area, not from a threat to the career standpoint, just from a responsible patient-provider relationship standpoint. The tools just are not there yet. You said when you introduced this, I think Curtis was talking about, or there was a comment about the dream and the nightmare. And one thing we have to be mindful of is that when you go through large statistical models, which effectively AI is, you can end up with hallucinations. And hallucinations are minimize and may have minimal impact in low risk scenarios, but interventional cardiology by and large is not a low risk scenario. And so I think that's where there has to be a lot of responsible usage. And that's where understanding the technique, if not the specific algorithm, because that's not the case, the technique and the rationale behind how it exists, it can be really informative. And I think that's something that interventional cardiologists should invest some time in because the field has been developing. It didn't come overnight. It's been around for about 10 years, if not longer. And this is just where we are now, and it'll continue to accelerate. So that's where I'll leave my comments for now.
Professor Khera, add?
No, I think the key aspect of publishing these articles in mainstream clinical journals is to first create awareness of the scope of the evolving science and how, traditional care models might evolve over time. And unless you forecast that for clinicians, it's challenging for them to sort of adapt their practices in advance of what's coming on the horizon. Second aspect I would point out is there's a lot of learning that would have to become a part of the, practice about how to think algorithmically, how to think, if your algorithm guides care a certain way, how to be a Bayesian person who can think about my pretest probability for a certain disease, how this tool might evolve and change how I deliver care to patients. So that training for our, emerging, both established and emerging proceduralists would be an important critical aspect. So I hope this is one of the many aspects that's, JSCAI as a journal touches upon on AI and interventional cardiology, but the future work is more specific to tools and models and how clinicians should learn and adapt their practice in response to them.
Well, I think this has been an extraordinary conversation. The journal issue speaks for itself. Each of these articles is amazingly educational. We'll close by getting a final word from each of you. Mr. Rooney?
Yeah, the newspaper had an article today by quoting Bill Gates and saying physicians and teachers will be obsolete in 10 years. I beg to differ. And I think it goes to what we're talking about is this is a tool, and we're going to use the tool to be able to treat patients and create safety for the patients. I really want to work toward avoiding the nightmare and treating patients. And I know physicians have a huge role in that.
I think what we're highlighting here, and I think what Dr. Khera's paper at a high level highlights is the opportunity in interventional cardiology. And what we try to focus on is the responsibility of interventional cardiologists. And I think when we think about that, then it becomes incumbent upon us to understand these tools and to understand where we can utilize them most appropriately and take leadership in that space.
And I'll just echo that sentiment. I think there's a lot of innovation that is in the works. We'll go through the pipeline, but in the end, it's the clinician who's deciding on behalf of the patient what's appropriate and what's important to do. And I think I hope we can actually train and learn and adapt our workflow so that we can do it well and effectively and use these tools to actually improve patient care and outcomes.
So I'll close by thanking all of you. I've learned so much from you through the years, and in particular through these wonderful papers. Thanks, Sky, and thank Curtis and Amanda for allowing us this opportunity and this platform to address one of societal's pivotal issues of the day. So thank you all very much.